वॉल्यूम नहीं आ रहा बेटा?
तेरा आवाज आ रही है?
बोले बोलो।
तेरा आवाज आ रही है आपको? आ रही है?
हेलो।
सर आवाज आ रही है मेरी?
बिल्कुल आ रही है। ठीक
लेकिन
है।
आपकी नहीं आ रही सर।
नहीं आ रही? अच्छा, आपकी आवाज़ मुझे आ रही है।
सर बोलिएगा। अब बोले सर। मेरी आवाज आ रही है सर? पता नहीं क्या मसला है। सर आवाज आ रही है?
आपकी आवाज़ आ रही है मुझे।
आपकी भी आ रही है
मेरी
सर।
आ रही है? ठीक है। बिस्मिल्लाहिर्रहमानिर्रहीम। नहमदुहु व नसल्ली अला रसूलिल करीम। Good morning. Happy rainy day. Today we are going to discuss very important topic from your examination point of view, and it is a very important topic for your whole life. So you must listen, and you, when an examiner give you command, today we are going to discuss about an important topic, that is the examination of motor system. So examination of motor system is almost same in adult and the peds, but little difference in neonatal examination, and in children you have to do you have a limited command. You must listen it and you perform it according to your command. If you have a command of examination, you check the more power of the muscle, you perform the power. Don't check the tone and all these things. Okay. And if you have a command for a particular reflex, you must do that reflex according to your command. But the examiner want to see your proper method, how you are performing your examination. So the key point of today of my lecture, according for the motor system, the examination, the following and compare two sides. When you examine the patient for the motor system, remember always you have to compare both sides of the limbs. Okay. Note any abnormality and its location. It is an important. First, do the inspection, but before going to do the inspection, you have to introduce yourself, and then you take a consent from mother if a small baby for the motor system examination. After your introduction, after a consent, you do the proper exposure of the patient. Okay, upper limbs, you have to remove the shirt and see the both upper limbs. Simultaneously in the lower limb, you have to expose the both limbs. Okay, So these are the important, little but very important points which will help you in your examination. Okay. Then you listen the command or read the scenario in which the command is given to you. Check the power of the muscles, check the reflexes. Once again, the reflexes, there are two type of the reflexes. One is the deep reflex, which are known as the tendon reflexes. One are the superficial reflexes like corneal reflexes, abdominal reflexes, cremasteric reflexes, anal reflexes. So first listen the command, okay? Then check the movements of the patients, the coordination of the movements, the involuntary movements, whether it is a choreothyroid movements, whatever movements you notice, you have to explain to your examiner. And then final, the gait. If baby is in walking condition more than 1 years and 2 years, and baby is able to walk, you have to check the gait. Okay, there are certain different type of the gait we will learn in our lecture as well. So this is an important topic, and in your whole life you have to read it. You do the practice in your wards and on your colleagues, perform the examination, follow the instructions, and the method should be correct. These 3 points are very important in your motor system examination. We will discuss one by one. First, you inspect. For the inspection, you do the expose the limbs and compare corresponding parts of both sides. The muscle of dominal limb have a little more bulk than non-dominal limbs. It may be decreased in wasting or atrophy and increase in case of the hypertrophy. So, if you have seen the wrestler or bodybuilder, their muscle become hypertrophied because of the excessive use, the exercise, and all these things. But the patient is lying on the bed, a patient is weak, patient may have wasting. You check the bilateral symmetrical wasting. If it is minor or small, it is difficult to pick up until it is fairly advanced, while unilateral localized wasting is clearly detected. The wasted muscles are small, soft, flappy. The wasting is a feature of the lower motor neuron lesions. If unilateral wasting, you may think about a poliomyelitis, in which the disuse, atrophy, the limb of affected limb is weak, thin, and power is also decreased. So you can pick up wasting. If it is unilateral, you can pick up easily. In case of hypertrophy, in true hypertrophy, both muscle bulk and power are increased. It occurs in response to excessive use of muscles, as in bodybuilders and athletics. It can also occur in myotonic disorders as well. Then you should check for the fasciculations. These are the involuntary contraction of group of muscles and fibers innervated by single motor neuron and appears as a fine. So you uh, check the fasciculation as well when you give the little stimulus to the muscle. After inspection, you should check for the tone of the muscles. Tone is defined as the resistance felt when joint is moved passively. Patient cooperation and relaxation are necessary for proper assessment of the tone. Patient should lie supine and be relaxed and comfortable. Okay. Tone may be increased in case of the hypertonia or may decreased in case of it is known as a hypotonia. The hypertonia, there are two types of the hypertonia. One is spasticity and other is rigidity. So the spasticity resistance rapidly increase first few degree of passive movements, and then movements continues, which suddenly decrease. It resembles opening or closure of clasp knife, and it is also called clasp knife spasticity, and it is a sign of upper motor neuron lesions. So first resistance increase, then it suddenly decrease. Okay. In case of rigidity, there is a uniform sustained resistance throughout the range of passive movement. This resembles bending of the lead pipe and is also called lead pipe rigidity. It occurs in lesion of the basal ganglia. So you have to differentiate the tone, hypertonia, whether it is spastic, it is rigid, you can explain to your examiner. Okay? And rigidity, the tone is increased, uniform, sustained throughout, like a lead pipe, and mostly when the basal ganglion insult or lesions in the basal ganglion, it is a rejection. Power of muscles, it is an important part of the examinations. Okay, so you must know the grading of the powers. What is the zero grade power? What is grade one? What is grade two? What is grade three? What is grade four? And what is grade five? And power varies in individual. It is important to compare muscles on both sides to detect mild weakness, and there are certain definitions like hemiplegia, monoplegia, paraplegia, diplegia, quadriplegia. These all are the medical terminology. You must remember the meaning, the definition of these words. In hemiplegia, mostly it is a weakness of one upper and one lower limb on the same side of body. There's a hemiplegia. It means the right side hemiplegia, left side hemiplegia. If you have a decreased power on the right upper and right lower limb, you must explain. Okay, and this is a right side hemiplegia because the power is decreased in upper and lower limb on the same side. In other words, uncrossed hemiplegia. The cranial nerve involvement and hemiplegia are on the same sides. And crossed hemiplegia, the cranial nerve involved on the one side and the hemiplegia is on the opposite sides. So, like the facial nerve, trigeminal nerve might be affected on the right side, and you have a weakness noticed in the right upper and right lower, left upper and left lower. So that's a crossed hemiplegia. In monoplegia, it is defined as weakness of one limb. Okay, that's known as monoplegia. The paraplegia, the weakness of both lower limb. Diplegia, the weakness of the both upper limbs. If both upper limbs having a weakness, the power reduced, power is normal in the lower limbs, you label as diplegia. And if a weakness in both lower limbs be symmetrical, and you can label as paraplegia. And like in case of the Guillain body syndromes, you have a weakness symmetrical in both the lower limb and in ascending form. But in case of poliomyelitis, mostly the monoplegia, the one limb is involved. In quadriplegia, the weakness of all four limbs. Okay, the for both upper and both level limbs are involved. Okay, so you can assess the power, and you must define whether it is normal power, it is a patient having hemiplegia, monoplegia, paraplegia, diplegia, quadriplegia. So power varies in individuals, and you must label after, and you can define after your smart examination. So grade of powers, it is an important when patient having no movements and no power, you can label as it as a complete paralysis. Grade 0 power. In grade 1 power, you notice the flicker of contraction only of the toes or fingers. In grade 2, a patient can move limb when gravity is excluded. Means the limb moving horizontal on the bed but not against gravity. In grade 3, a patient can move against gravity, can lift limbs from bed, but not against resistance. Okay, so patient can move the limb against gravity, but not against resistance. Grade 4, patient can move against resistance, but power is less than normal. And grade 5 is normal power. Okay, so you should perform. If you have a command to check the power of the muscles, you must give command and see and check the power, and you should define. If a patient can lift her or his limb against gravity but not against resistance, you should label that grade 2 power. And if patient having grade 3 power, because patient can move against gravity but not against resistance. And if patient can't move limbs against gravity and can move the limb horizontally, not in vertical direction, on the bed, you can label grade 2. Against resist gravity but not against resist, you should label as grade 3. And if patient move against resistance but power is less than normal, you should label as grade 4 power. And in grade 5 power, that's normal. So you can check the muscles individually, the small muscles, the muscles of the hand, the muscles of the feet, and you should be able. But in small muscle of hand, usually we are not giving command to you because the kids are small, they can't understand. So but being a doctor, you must know these, because in adults you should apply these methods, and you give the command to the patient and perform your examination, and your method should be correct. In upper limbs, the small muscle of the hand, all small muscles of our hand are supplied by T1 spinal segments. The abductor pollicis brevis. It is supplied by the median nerve. Ask the patient to abduct the thumb at right angle to the palm against the resistance to check the power of abductor pollicis brevis. And opinion pollicis, this is another muscle. It is supplied by the median nerve. Ask the patient to touch the little finger with the thumb. Then try to separate them with your index fingers. And adductor pollicis brevis, it is supplied by ulnar nerve. Ask the patient to adduct thumb towards the palmar surface of the index finger against resistance. And in lumbricals muscles, first and second lumbricals are supplied by the median nerve, and while third and fourth are supplied by ulnar nerve. Ask the patient to flex the metacarpophalangeal joints and extend interphalangeal joint against resistance to check the lumbrical muscles. The flexure of the fingers override your index and middle fingers. Ask the patient to squeeze them while you pull to free them. And the extensor of the fingers, ask the patient to open the fist against resistance. And after the hand massage, you check the flexure compartment, the flexor muscles of the wrist joint. Ask the patient to bring the tip of the fingers in front of his forearm against resistance. You apply the resistance, ask the patient to bring tip of the fingers towards the forearm. Extensor of the wrist, ask the patient to make a fist. This involves firm contraction of the flexure and extensor of the wrist. Try to flex the fist while he resisted. There is another method. Ask the patient to grab something firmly in his hand. If extensors are weak, the wrist is flexed. Brachioradial muscles. Ask the patient to flex the elbow against resistance while arm is in midway to check the power of brachioradial muscles. The bicep, ask the patient to flex elbow against resistance while arm is full in supination position. And the extensor of the wrist is tricep. Ask the patient to straight the flexed forearm against resistance to check the power of tricep muscle. In the lower limb, dorsiflexion of the toes. Ask the patient to move the toe upwards against resistance, and dorsiflexion of the foot. Ask the patient to move the foot upward against resistance. Plantar flexion of the toe. Ask the patient to move the toe downwards against resistance, and plantar flexion of the foot, ask the patient to move the foot downwards against the resistance. So in the toe and foot, you have to check the dorsiflexion, the plantar flexion of the foot and toes, the dorsiflexion of the foot and toes, to check the power of extensor and flexor compartment of foot and toe. And then you should check the power of knee muscles. The extensor of the knee bends the knee and ask the patient to straighten it against resistance. And flex of the knees, raise the leg up from the bed and support the thigh with the left hand and hold the ankle with the right, and then ask the patient to bend the knee against resistance to check the power of flexor muscles of the knees. And the extensor of the hip, lift the leg up while knee fully extend and ask the patient to push it down against the resistance. And check the power of flexors of the hip, ask the patient to bend leg up at the hip against resistance. And adductor of the thigh, ask the patient to bring abductor limb towards the midline against the resistance. And abductor of the thigh or vice versa, place the patient's leg together and ask them to separate against resistance. And if would you like to check the power of muscles of the trunk to test the muscle of abdominal wall, ask the patient to lift his head up from the pillow against resistance. Abdominal muscles can be failed to contract. If muscles of lower limb abdomen are paralyzed, the umbilicus moves upward and vice versa. This is called Beaver signs to check the power of the abdominal muscles. It's known as Beaver sign. Then reflexes. It is very important in your examination point of view, and it is a major station for your examination in your OSCE. So the reflexes is important topic. You must read, you must perform, your method should be correct, and proper exposure of the patients. Once again, I told you about that you should introduce yourself in the and take consent and perform the methods, how to hold a hammer, where it should be strike on the tendon, what is the correct method, because the examiner is present in front of you and he will check you. Okay, what is your method? It is a normal method, correct method, or you doing incorrect method? Okay. So the reflexes, these are dependent on the reflexes which consist of an afferent path and efferent path. The front is sensory limb transmits the impulse generated by the stimulation of the receptors to communicate neurons, which in turn send the stimulus to the efferent organ muscles through the efferent motor limbs. All reflexes should be intact for reflex to be elicited. So the sensory and motor both should be intact. Each reflex is carried out by one or two spinal segments, which is called root value of that reflex. It should be remembered reflexes are of two types. One are the deep reflex, which is known as tendon reflex, and other are the superficial reflexes. Okay. The deep tendon reflex are the knee reflex, the ankle reflex, bicep, tricep, and the superficial reflex are the corneal, conjunctival, umbilical, cremasteric, and anal reflexes. So you must remember, if you are good, the root value of the pertinent tendon are the jerks. The ankle jerk, ankle joint is supplied by S1, S2. Knee jerk, you should check L3, L4. Biceps, C5, C6. Brachioradial jerks, you check. You are checking the roots of the C5, C6, and an extensor compartment like tricep jerks, C6 and C7. The plantar reflex of S1, abdominal reflex T8 to T12, cremasteric reflexes are L1, L2, anal reflex S3, S4, and conjunctival and corneal reflexes are the cranial nerve 5 and 7. So this is the methods, and if you want to check the reflexes, deep reflexes are tendon reflexes are the ankle jerks, the knee jerk, the bicep jerk, tricep jerk, brachioradial jerk, and reinforcement for the reflex of the lower limb. Ask the patient to clench the hand or hook the fingers of both hands together and then pull them and away from each other without disengaging. For reflexes of the upper limb, ask the patient to clench the teeth. This phenomenon of reinforcement only lasts for less than a second. So mostly we are not performing the children, but you must know about this one. Bicep jerks. Flex the elbow at right angle and place the forearm in the semi-pronate positions. Place the thumb or index finger of your left hand over the tendon of the biceps in the cubital fossa and strike it with the hammer like this. See in the figures here, the thumb of the examiner and the tendon of the biceps. This is the bicep tendon, this is the bicep bulk muscle, and this is striking of the hammer, and you should see the reflexes over this area. The tricep jerk, place the forearm on the patient's abdomen, elbow being flexed at the right angle, strike the tendon of the tricep above the oblique and see the contraction of the tricep. The brachioradial jerk, this is also called supinator jerks. Flex the forearm at the elbow and place it in the semi-pronate positions. Bend the hand slightly towards the ulnar sides. Strike the tendon of the brachioradials proximal to the styloid process of the radius. See the contraction of the brachioradials. Ankle jerk. Patient should lie supine, flex the leg slight and place it in externally rotate positions. Dorsiflex the foot with the left hand and strike the Achilles tendon with the hammer. See the contraction of the muscles. I would like to show you picture. This is a ankle. Okay. And this is a hold this in this way and you strike on the tendon with hammer. And knee jerk. Patient should lie supine, flex the knee and support it with your left hand. Feel for the tendon of quadriceps and strike it between the patella and tibial tuberosity. With the hammer, see contraction of the quadriceps. Colonus. This is the involuntary oscillatory muscular contraction and relaxation involved by sudden strength of the stretch of the muscles. The colonus is the involuntary oscillatory movements or muscular contraction and relaxation involved by a sudden stretch of the muscles, and mostly we perform the ankle colonus and the patellar. So the interpretation of the tendon reflexes. All tendon reflexes are brisk or increased in case of the upper motor neuron lesions, and diminished or decreased absence tendon reflex are in case of the lower motor neuron lesions. So if you find the reflexes are diminished, you must say that this is a lower motor power is reduced, and all these things you should explain to the examiner that the reflex are diminished, power reduced, so it could be a lower motor neuron lesions, and brisk reflexes are colonus positive. It is a sign of the motor neuron. So the superficial reflexes are the plantars, abdominal, cremasteric, anal, conjunctival, and corneal reflexes. We will elaborate one by one. In plantar reflexes, normal response in plantar reflex of the greater toe along with pelagian induction of the toes. This is also called downward going plantars and negative Babinski sign. If there is an extension of dorsiflexion of the great toe, usually accompanied by fanning of the other toes. This is called upgoing plantars. Extensor plantar of positive Babinski sign. And interpretations, the upgoing plantar is the most significant sign of the upper motor neuron lesions. Okay, so look at this is a normal plantar. The great toes downward along with the other one. Here the abnormal reflexes are positive Babinski sign. The toe is going upward and there are the fanning of the other toes. So the causes of the upgoing plantars are the upper motor neuron lesions, the hypoglycemia, deep coma, post-epileptic fits, and age below 1 years. You have a upgoing plantars. Offenham signs, it is another method to elicit the plantar reflex. The extensor plantar response is elicited by the rubbing over the crest of the tibia. And there is a Gordon's reflex. Extensor plantar reflex is elicited by the pinching of the Achilles tendon. So if you are performing the three methods, the Babinski's, the Offenham's, and Gordon reflex, examiner will be happy that you have to performed all three methods to elicit the extensor plantar response. And Achilles tendon, both these signs are present when corticospinal lesion is widespread and severe. So you must remember the Oppenheim sign, the coordinate reflex, and if presents, it is a sign of the corticospinal lesions, and the lesions is severe, widespread, and Hoffman signs, it is opposite to the Oppenheim signs in the lower limb. Hold the terminal phalanx of the patient's middle finger between your thumb and index finger and flex it terminal interphalangeal joint and then flick it into the extension with your thumb. If sign is positive, there is quick flexion of your patient's thumb. If it is hyperreflexia, if unilateral positive, it is strongly suggest upper motor neuron lesions. It should not be confused with the Hoffman sign in deep venous thrombosis. This is the Hoffman signs. Finger flexion jerk. Place tip of your middle finger and index finger across the palmar surface of the proximal phalanges of the patients. Then lightly tape your own fingers. A slight flexion of the patient finger is normal, but a brisk contraction is suggest hyperreflexia. So these are the small muscles that have the hands. You perform the open sign, the finger flexion jerks. Rossolimo signs. The Rossolimo signs flex the distal phalange of the toe into the extensor with your finger and then allow them to fall back into normal position. A positive response is a brisk plantar flexion of the great toe. This is a sign of pathological hyperreflexia. It is a counterpart of movement signs in the lower limb. It is particularly helpful when plantar response cannot be obtained because paralysis of extensor hallucis longus. Once again, the Rossolimo signs the flex the distal phalange of the toe into extend into the extension with your fingers and then allow them to fall into the normal position. The positive response is brisk plantar flexion of the great toe. This is a sign of pathological hyperreflexia. It is the counterparts of the Hoffman signs in the lower limb. It is particularly helpful when plantar response cannot be obtained because paralysis of the extensor hallucis longus. So it is a rare test, but if you know, it is a good. Absent plantar reflexes, sometimes no plantar response is obtained with the usual stimulus. One of the following could be a reason. If patients having cold feet, sensory loss over S1 dermatome, paralysis of the muscles of great toe, spinal shock due to the transection of the spinal cords. In all these conditions, in all four conditions, you will be notice absent plantar response in the patients. Coldness of the feet, the sensory loss, paralysis of the muscle of great toe, spinal shock. Abdominal reflexes. This is the give it here. See the directions how you will perform the abdominal reflexes. The patient should be warm and relaxed, lying in the supine position with a low pillow supporting the head. Draw a pin from lateral part of the abdomen towards the midline on the other sides. Chiromastoid reflex. Scratch the inner aspect of the upper part of the thigh. Normally, there is elevation of the testis, and this reflex may be lost in upper motor neurons. The inner reflex, the S3, S4. Scratch the skin near the anal margin with a sharp object. There is the contraction of the anal sphincters, and this is known as the anal reflexes. And you must check the coordinations in the upper limb. In upper limb, you should give the command to the patient, the finger nose test, finger to finger test. In lower limbs, the heel knee test and heel toe test. So these are the tests you will perform for the coordinations, and you also check the gait as well. So the involuntary movements, first the tremors. These are the rhythmic involuntary movements resulting from alternating contraction and relaxation of the muscles of groups of the muscles. These involve the peripheral parts of the body like hand, head, tongue, and most the important causes of the tremors are the anxiety tremors, thyrotoxicosis, essential familial tremors, and senile tremors. So these are all the involuntary movements. Okay. Parkinsonism tremors. Parkinsonism is a disease in old age, not in the pediatric age group, but you must differentiate. You must know the Parkinsonism tremors from the intentional tremors. In Parkinsonism, these are slow and pause. Typically, there are pill rolling movements of the thumb. Uh, Tremors are partially suppressed during voluntary movement and disappear during sleep. Other features of Parkinsonism check for the rigidity, hypokinesia, and gait. These are the extra helpful things in case of the Parkinson tremors. In intentional tremors, ask the patient to catch an object, say a pencil held in your hand. Tremors are absent at rest, become prominent as patient approach the object and disappear thereafter. Intentional tremors are a feature of cerebral dysfunction. So these are the prominent when patients are writing, doing some things, performing tasks, but they disappear at the rest. Flapping tremors ask the patient to ask how to stretch arms and dorsiflex hand at rest. Jerky movements of the hand occurs due to the flexion and extension of the wrist and fingers. Causes of flapping tremors are respiratory, renal, hepatic, and cardiac. Ethetoid movements, these are the slow rhythmic movements, prin- principally affected the distal parts of the limb. The combination of choreoform and ethetoid movements may occur in the same patient. Chorea is also another type of the abnormal movements. So chorea is like a Greek word, and it means a dance because dance having every step is in use. So choreo movements are the different here. Every so not a symmetrical, identical movements, but the different movements of different steps. And attitude movements, these are the slow rhythmic movements principally affect the distal part of the limbs. Myoclonus. Usually, you have seen the myoclonus or epilepsy, certain fades or convulsions or involuntary movements in the myoclonus. So these are the sudden like contraction that involve one or more muscle or whole muscle. These sometimes occurs in normal people when falling asleep. Also a feature of the epilepsy. Dystonia. These are the similar to the thyroid movements but involve proximal parts. They are turning or twisting movements of the limb or trunk. Sustained abnormal contractions and limb posturing may result. Spasmodic torticollis and dystonia muscularum deformans are an examples. Gait is important component of motor system. You have to the check, ask the patient if he is unable to walk. You have to notice the different type of the gait. Okay, the spastic gait. This is a seen in upper motor neuron paraplegia. The patient does not lift his feet from the ground completely, so that thus remains in contact with the ground. The legs swing to forwards and outwards in a circular fashion. Hemiplegic gait is a spastic gait in which only one leg is affected. The high stepping gait, this is seen in patients with bilateral foot drop as a result of weakness of the extensor of the feet. As in polyneuropathy, patient lift the foot high to clear the toe from the ground and then return it with a loud slapping noise. Drunken gait, drunken gait, patients walk on a broad base in a reeling manner. This occurs in cerebral lesions and unilateral lesion. Patient tend to stagger towards the affected side, and it is known as a drunken gait. Waddling gait. It is important in pediatric as well. The body is sway from side to side as each step is taken. This occurs in proximal muscular weakness and myopathies, and mostly in bilateral or congenital hip dislocations. You notice the waddling gait. Parkinson gait. Okay, in Parkinson gait, it's characterized by forward with flexion at the hip and knee, arms are flexed at elbow and adducted at the shoulder. There are no associated movements during walking. Walking is initiated slowly with a short, rapid steps, feet dragging or sliding along the floor. The shuffling gait. As the upper body gradually bends or lean forward further ahead of the feet, the pace tends to accelerate in an attempt to maintain an upright posture. So that's a fascinating. Look at the posture, the bending, the flexion of the upper limb. These are the small steps, and patient um, maintain a balance. So these are small rapid steps bending forwards. Typically, you have seen OPD cases, and you may label that this is a Parkinson gait. So gait is also important, and if a baby a patient having in congenital dislocation of the hip, you have waddling gait. So thank you for listening this lecture. If you have any question, you must ask. Tariq, and at the end we have a video on the neonatal lectures, and if you have my email or you have a moderator email, you can ask. We will give you lecture, whole lecture, for your preparation for the exams. How are you? You welcome. You welcome. वीडियो वीडियो इसको बंद करो. ये बस वीडियो प्ले कर रहे थे, बस ठीक है. क्वेश्चन आंसर सेशन ना ले. We have a question answer session. After that, we will show you this video. Okay, we have a Ramsha. We have a certain videos which will be helpful, and I have sent you the pic, and it is better you will perform on the patients or in your colleagues or in yourselves in the home and read the method, because the proper method is important in the examination. It is similar to the adults and the older, but the neonates children is a little difference, and you have, but you'll be able to perform like reflexes, how we will check the reflexes, what is the correct method to hold the hammer, and where we should apply on the tendon. So these all are the practice making. Okay, and thank you. I will try my best to send you the video as well. Okay, any other question? And I will send you this presentation as well, or you can ask moderator, he will give you the video, he will give you the picture as well and send you the presentation. So thank you, and this is a little video which will be helpful for you in pediatrics. You must watch this video and enjoy. Thank you very much.
I'm Carrie Neville.
And I'm Robin Cook.
We are the pediatric neurology residents.
Yep, currently second year residents, going to be third year, but really PGY 2 neuro people equivalents. So.
Soon to be 3.
Mm-hmm.
So we thought that for our video we could go over some highlights of the pediatric neurologic exam for some of the other neuro residents. And wanted to capture a couple of different age groups and a couple of different parts of the exams.
Mm-hmm. And things that kids are and are not able to do at different ages.
So today we're going to go through some of the things that you wouldn't do in an adult patient that are useful to look at in a pediatric patient. We'll start with looking at some of the things on the newborn exam. So one of the things we usually assess is the infant's tone. Carrie is going to start by doing a test for head lag. And a normal baby, you'll see that Millie actually holds her neck up quite nicely there. In babies with hypotonia, you'll actually see the head kind of lag a little bit in the ventral position. And as you can see, Millie is holding her neck up quite nicely. In a baby with hypotonia, you would see that her arms and her legs and neck would kind of droop over and fall straight down towards the and so what you do in this exam is put your hands basically under the baby's axilla. And in a baby with low tone, you would see that the baby's arms would sort of start to go up towards the ceiling, and the baby might actually slip through. The first one of the other reflexes we'll demonstrate is the rooting reflex. And so Carrie's just going to stroke right next to Millie's mouth there. And what you typically see in a newborn baby is that the baby will turn its head towards the side of the Carrie will next check the grasp reflex, which does tend to extinguish by the time an infant is around Millie's age, so around 3 or 4 months. A useful maneuver if you want to get the baby to open its fist up so that you can actually check this reflex is to kind of stroke along the side of the hand here. And we can actually demonstrate the plantar grasp reflex as well. An upgoing or extensor toe response can be normal in babies up to the age of about a year. As we're going to demonstrate the moral reflex, which basically is where you shows it, the infant's arms will extend way out, sometimes out forward and sometimes out to the sides. That reflex typically extinguishes around 3 to 6 months of age. And so it's important to check and make sure that that's symmetric.
So next we wanted to demonstrate some physical exam findings that you might want to elicit or observe in a 2-year-old. We thought we would start with kind of mental status or development, kind of normal interactions that a 2-year-old would have. In general, for language development in a 2-year-old, you would expect them to start saying 2-word sentences and have up to 50 words, but this can be very variable. What you see in clinic, you can kind of get a sense from the parents about how they think that their language is developing. 50% of speech should be intelligible by an unrelated adult at this point.
Okay. Where's the giraffe's nose? Right there. Where's his ears at? Right there. It's a pretty fun thing, huh?
So here we can also use observation and toys to test things like fine motor and coordination.
Alright, so here I'm going to draw a circle. Is this a circle? Can you draw a circle? So see, she draws a circle very nicely.
She can mimic certain
Okay,
shapes.
I'm going to draw a straight line. See, it's a straight line. Can you draw a straight line? Good job. Can you show me your tongue?
Good job!
Can you close your mouth? Can you open it? Can you close your eyes real tight? Real tight. Good job. Can you jump? Good job. Jump one more time. Jump.
Great. So for almost 5-year-olds, most of the things that you want to do on your neurologic exam are going to be the same as what you would do in an adult. So we thought we could demonstrate some strength testing.
Okay, let's make some muscles up like this. Put your arms up way high like this. Put your elbows up. Put your elbows up. You keep them right there. Don't let me push them down. Don't let me push them down. As hard as you can. Good. Pizza box. I'm going to keep your hands real flat like this. And you don't want to drop that pizza, okay? You don't want to drop the pizza. Okay, close your eyes and keep holding that box straight up. Keep holding it right there. Keep holding it. Why don't you start over here and walk over to my friend Carrie over there on your tiptoes.
Good job!
Good job.
Now go.
Can you walk back to me on your heels?
Woo.
Good job.
3, 4, 5. Extra tricky.
Awesome. That looks like fine.
Good. What are you looking at?
There you go.
Did you know that? What are you gonna do for your birthday?
Like all of my preschool friends.
Oh, fun.
What?
Did you say preschool friends?
Oh, preschool
I
friend.
had something.
I understand.
Cheap this one.